So this is a full workup of ischemia, which is like, that's what most what we do every day. 48 years old, presented with right-sided weakness. So the CT head non-cont showed hyperdensity in the left servian fissure, what we call dense MCA sign, which means a thrombus within the left MCA. At a different slice level, we can see very subtle hypodensity in the left frontotemporal lobe. We always recommend like excessive windowing, so we can better see the hypodensity here, which is still subtle, but it is definitely more obvious than the first one. The next step is always to get a CT head angiogram, and that confirmed the complete occlusion of left MCA. I do recommend always looking at the brain soft tissue on the CT head angiogram, as it might demonstrate the area of hypoperfusion with respect to the normal enhancing parenchyma. And the other thing we do now is a stroke perfusion study to assess the size of the core infarct as reflected by cerebral blood flow less than 30% and area of salvageable tissue or ischemic penumbra, which is reflected by Tmax more than 6 seconds. Here we see it is more than 100, so this is considered a pretty big infarct, and the mismatch ratio is very big. Like when it is more than 1.8, this is considered a good candidate for thrombectomy. I always also recommend look at the color-coded map, even if you have this report, because sometimes the area of hypoperfusion doesn't meet these thresholds, but that doesn't mean it do not exist. So review them, and I have a couple cases where it is missed on the post-processing, but I was able to see it on the color-coded map. This patient went and underwent thrombectomy, trial of thrombectomy. Unfortunately, it was unsuccessful. So the follow-up CT head after the angiogram, it showed increased area of edema and central hyperdensity. So here we are between two possibilities. Either it is contrast staining or hemorrhage. How you would differentiate between that? If you have dual energy CT, we can do iodine subtraction. If it goes away, this is contrast staining. If you don't have it, you can do a follow-up, short-term follow-up CT head, like within 4 to 6 hours. And if this density decrease, which like in this case, this is most likely contrast, and we follow it up until completely resolved. The final step is to get a brain MRI within 48 to 72 hours to look the final outcome of the infarct, which is, as we see in this patient, and also to look if there is any evidence of hemorrhagic transformation, especially if it is like petechial hemorrhage, as we see on the susceptibility signal. And that concludes a full workup for an acute ischemia.